Good afternoon, everyone. Thank you for coming to today's Tuesday topics, APRV and mean airway pressure, a continuation of oxygenation strategies in critically ill patients who have de-recruited lungs. So without any further ado, let's just begin with APRV and mean airway pressure. So here we're just taking a quick look at a ventilator graphic. This is the Puritan Bennett 840. Here at Grady, we use 840s and 940s. We don't actually have Dragers, although we'll have some picture of Dragers or Hamiltons. So some of you from other places may use those ventilators, but conceptually, it's all the same. So I want you just to take a look here at our style of ventilation. We look down here, we see the patients on SIMV. That's the mode. The target is volume, and the target volume is 500 mLs. The delivery of the volume, which is called the flow rate, is relatively slow. Typically, that's at 60 to 80 liters a minute. It's the rate of speed that we're delivering the flow of gas. This is relatively slow. And you can actually see that when you look at the pressure in the airway as you're delivering volume, it has a slow ascent. And this, of course, is inspiration. And then the yellow is exhalation. And on this particular ventilator, we have pressed an inspiratory hold key. That inspiratory hold key gives us something called the plateau pressure. Plateau pressure is a poor man's method, very primitive, but usable to tell me about whether or not my alveoli are effectively recruited. We would always like to see our plateau pressure less than 25. Here, it's 40. But very important, what I want to appreciate is that I actually have to get a mean airway pressure that is close to 40 in order to pop open the lung. So really important to understand the role of the plateau pressure, which tells me about lung opening pressure. That lung opening pressure is relatively close to 40, and that the mean airway pressure, which is what maintains lung opening, is 23. So clearly, whatever it is right now that we're doing is not working. So by the way, we have slow flows. So that means that the gas is delivered over time, spending more time in inspiration than in exhalation. And you see that in this IE ratio. This is not seconds, it's just percent. 1.5 components of the cycle is spent in inspiration. 1 component of the cycle is spent in exhalation. And you can see that our patient is on a PEEP of 12.5 and an FiO2 of 100%. Now, without knowing the patient's blood gas, we don't know if this is working. But this is an extraordinary amount of support that we're supplying to our patient. We're giving him PEEP of 12.5, 100% FiO2, slow flow delivery, which means a prolonged time of inspiration, meaning that we're flowing the gas in over a period of time and trying to open up the alveoli. So without a blood gas, we can't know if it's working, but my tendency would be to tell you that it's probably not. Not really going to talk about expiratory pause today, just really want to look at that inspiratory pause, which gives us a measure that appears right here. That is known as the P plateau, and the P plateau tells me about alveolar compliance. I would like that less than 25. Anything greater than 30 is completely and profoundly unacceptable. Okay, so I'm going to move to just some basic drawings that I just applied to help us understand the concept, because this is really the key to understanding why a decision is made to place a patient on an APRV. Airway pressure release ventilation, a great strategy. We don't really have 100% evidence that says it's going to help us, but it's something that we like to try early when we have patients who have failure of PEEP and FiO2. Okay, so on my ventilator, there's a hard key that says inspiratory hold. Hard key means it never changes. It always gives an inspiratory hold. I press that and I release it. And the ventilator at peak gas flow, so at the peak of distribution of the flow of gas, will shut the exhalation valves. And now that gas, that volume of gas, so it has to be done on a volume breath, that volume of gas is distributed across open alveoli. The less alveoli are open, the more that volume is distributed into the open alveoli, stuffing the gas into the open alveoli and yielding a high pressure. We know that we've opened the lung when the plateau pressure drops because more alveoli are open at the same or even greater tidal volume, giving us a much lower pressure. So very important to appreciate that we talk about peak inspiratory pressure. Peak inspiratory pressure is at the peak of flow of gas into the lung, and what pressure is being generated when that occurs. That incorporates the ET tube, the proximal airways, the distal airways, and the alveoli, and all of that being encased inside the chest wall. So there's a lot of variables in peak inspiratory pressure. When I press that inspiratory hold button, now I'm going to look at the plateau pressure. And that plateau pressure, remember, measures the total volume inside of the open alveoli. Less alveoli open, the higher the plateau, because I'm stuffing a big volume into a small space. That's why plateau gives you such fantastic information about how to open up your lung. All right. So in general, we'd like to see a peak pressure of less than 45. That first patient we looked at had a peak pressure of 47, not terribly elevated, but somewhat elevated. And we'd like to see a plateau pressure of less than 25. And our patient's plateau was 40, profoundly elevated and telling us that we have a patient who has a derecruited, non-compliant lung. Now, we already know that, right? Because we've had to apply 100% FiO2, trying to oxygenate the patient. We've applied 12.5 of PEEP, trying to open the lung. But so far, that has not worked, at least based on what we're considering. We don't have his blood gas, so we don't know for certain. Okay. Now, I'm going to say that now I'm going to add PEEP of 5. Now that PEEP of 5 is going to elevate my plateau pressure because I'm trapping gas in the lung, fresh gas, oxygenated gas, new flow gas, and that is going to keep my alveoli, hopefully, from collapsing. PEEP of 5, not going to open any alveoli, but it's going to keep the functional alveoli open and hopefully prevent you from collapsing. Now that's going to raise that plateau pressure. And here, what I'm showing you is a plateau pressure of 35. Well, remember, I would like your plateau to be 25 or less. When I add PEEP to that, I say, okay, I'm going to accept 30, but my plateau pressure is 35, which means my lungs are de-recruited. And I now need to think about what I'm going to do. Last week, I talked a bit about drive pressure. Drive pressure is sort of the new in methodology for looking at lung function. That's PEEP plateau minus PEEP. That's the pressure that is driving the gas into the alveoli, and we'd like to see that less than 15. So plateau here, 35 minus PEEP 5, that drive pressure is 30. We want to see that less than 15. Everything I'm going to do now is I'm going to talk to my respiratory therapist, my colleagues, my APP, my physician, the attending pulmonologist about the fact that I have a patient who has a drive pressure, plateau minus PEEP, of 30. Optimal is less than 15. And then I'm using 100% FiO2 and 12.5 of PEEP, but it appears actually that it's not working. So how long do I let my patient lay in a bed with this form of ventilatory support without progressing forward, trying to open the lung, trying to provide better gas exchange? I have to question that myself. I don't have to be a respiratory therapist. So I don't have to understand everything, but I can understand simple things. I can understand a plateau, which is measured when I press an inspiratory hold. I can understand a drive pressure, which is plateau minus PEEP. And I can understand that I'd like plateau to be less than 30, really less than 25 optimally, but less than 30. And I want drive pressure to be less than 15. So those are simple tools that we can utilize at the bedside that help us to appreciate and understand what's happening for our patient. So now we're going to look at this patient. This patient's on a volume control, and he's on a ACMV. And here is his peak pressure, which is 40. Which, okay, 45 is what I'm going to be worried about, but his plateau is 36. He's on a PEEP of 13, so 36 minus 13 is 23. He has a high PEEP plateau. He has a high drive pressure. His lung is non-compliant. That's what this is telling me. That's all I have to understand. His lung is non-compliant. So now strategically, I have to think about two things. I have to think about how do I protect his functional lung? And typically, I'm going to do that with a lower tidal volume. So right now he's getting a tidal volume around 398. I want his tidal volume lower because that protects his lung. But lung protective ventilation doesn't open your lung. All lung protective ventilation does, low tidal volume, is protect the alveoli that's already open. So I always want to use low tidal volume, protecting the lung, with a recruitment strategy. And the first recruitment strategy is always PEEP. Okay, my patient's on a PEEP of 13. His mean airway pressure is 22. His plateau is 36. I've got to drive up his mean airway pressure to open his lung. And you see right here where the inspiratory hold button was pushed, and you see that you have not allowed air to be exhaled. It's trapped inside the lung, and that gives me the PEEP plateau, which basically is what we will refer to as a static compliance measure. It's a poor man's measure, but it's a really beneficial measure that tells me whether or not my lung is functional. Okay, PEEP 13, plateau 36, PEEP 40, and now we appreciate that when we talk about the lung. So if we look at the lung and we say when you have collapsed alveoli, you actually are going to have a very wide drive pressure. When you have over-distended alveoli, meaning I'm just opening up too much lung and over-distending, or I'm over-distending the alveoli that are functional, I'm going to have way too much drive pressure. What I'm looking for is the appropriate drive pressure, less than 15, which tells me that I've opened your lung. So I have to increase your PEEP or increase your mean airway pressure, and I'm going to use strategies for that to actually achieve the lowest possible drive pressure with the best open lung. And that's the well-expanded alveoli. That's what my goal is at all times. Now, remember, it takes 4 years of education to be a respiratory therapist, and then a lot of experience to really look at ventilators and operate them appropriately. We're not trying to be respiratory therapists. We're trying to say when your driving pressure is too high and your PEEP plateau is high, we have to consider that this indicates that the lung is non-compliant. And that means that our patient basically has hypoxia and then hypoxemia, which then, of course, puts them significantly and profoundly at risk. So these are slides that I've used last week and even the week before, just as a summary to remind you that what you want to see is the lung open. When the lung opens, gas is going to flow in rapidly. Okay, so this is our starting point, and we have a slow uptake, and then we see a rapid uptake when the lung is open. So this is called low inflection point. That is the opening pressure that allows gas to flow rapidly into the lung. And this is actually the optimal PEEP. So in this patient, this is a PEEP of about 18. Okay, so right now he's on a PEEP of 8. This is a PEEP of 18. He should be at a PEEP of 18 so that as soon as the ventilator turns on, that gas flows past the ET tube, past the airway, directly into the alveolus in order to provide for gas exchange. That's called the sweet spot. If I over-distend, what I'm going to see up here is this over-distension. It's also called a beaking that you're going to see in a volume pressure scalar. Again, really requires advanced evaluation, advanced understanding of these scalars. But what I want you to appreciate is I want to open your lung and I don't want to over-distend the lung. So if I just look at a scalar, I can say at the point that I see the volume takes off, that's the opening pressure. And if I see that I end up with a beak at the end, that is considered over-distension. What I want to do is be somewhere right in here. And I'm going to adjust my PEEP and my tidal volume to achieve what we call the sweet spot, which is alveolar recruitment without over-distension. Oh, so easy to say. So easy to say, so hard to achieve. And even the most experienced therapists can have some struggles with looking at scalars, really interpreting it, and advocating for the right opening pressure without over-distension. But typically what we see is we see under distending pressure, under alveolar recruitment, and we see over distension of functional alveoli. So under recruitment too low of a PEEP, and overdistension, tidal volume that's too much for the functional lung. So remember, I'm going to treat this one by reducing your tidal volume. I'm going to treat this one by increasing your PEEP, or an easier way to say it, because then I don't have to define my method, is by increasing your mean airway pressure. Now, everybody on here, I don't know everybody on here, but I'm assuming that everybody on here is a nurse at one level or another. And we as nurses know that at the bedside, we're always chasing mean arterial pressure, because that's the constant pressure of blood flow in the artery. Mean airway pressure is the constant pressure of gas flow in the airways. And if I can open the airways and open the alveoli, I'm going to have better gas exchange. So just like you chase mean arterial pressure at the bedside, we're going to chase mean airway pressure with our ventilator. And that's going to be a really important concept. Now, if we just take a look at exactly what I've just said, is alveolar collapse and alveolar overdistension. We're looking at volume in seconds over time, volume over time, and pressure as it relates to volume. And you can see here that your takeoff really isn't at 10. Your takeoff is at around 15. See where, if I'm imagining 15, I can see that all of a sudden gas goes whoop, right into the lung. So first it's, oh, 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 whoop, oh, 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 whoop. But here's the thing. All I want is a whoop. I don't want the oh, oh, ohs. So I've got to set my pressure to the lung opening, or the lower inflection point. And then I'm going to set my volume so that I don't overdistend. Now, protective lung ventilation, that's what we talk about all the time, and that's fantastic. I think here in the practice at my hospital, we always start with the lung protective ventilation, and that would be 6 to 8 mLs per kg of predicted body weight. That's what everybody talks about. We've got a lung protective ventilation. We're using a low tidal volume. We're trying to prevent overdistension. But down here, we don't work very hard to support opening. And that's really, really important. We've got to support opening of the lung. That's incredibly and profoundly important. And we should be really focusing on that when we're looking at patients at the bedside. Okay. All right. So here's the thing. When PEEP is too high, for your comfort, for the patient's comfort, because it's putting a high workload on your right heart, you're not actually seeing that the patient has good gas exchange, so it's not really working. Your PEEP is 12, it's 14, it's 15, it's 18, it's 20, it's 22 or 24. Most of us don't see PEEPs at 22 or 24. We only saw that during COVID. But remember, COVID ARDS cards is very similar to ARDS. So if we're working with populations of patients who have loss of lung compliance in ARDS, we always have to ask the question is, when is PEEP too high? When am I uncomfortable with that PEEP? When is the patient uncomfortable with that PEEP? And when is it not working at all? And that's really the idea. So first, I want to just show basic conventional ventilation with 5 or 8 of PEEP. What I want you to focus on is this whole surface area is collapsed. Okay. Now, I'm going to start the video, and what you're going to see is as the breath goes in, half of the breath is wasted trying to pop open the alveoli, and then during exhalation, the alveoli will recollapse unless you put the patient at a level of PEEP that maintains alveolar opening. So you see that the standard breath didn't necessarily open the lung. It's actually the PEEP that opened the lung. Okay. And then I'm going to look at that again in a different way. And what this is a PEEP of around 18 with spontaneous breathing. And that, see those little distensions? This is actually APRV. And it looks like I gave you 2 APRV videos. I'm so sorry, because I wanted to give you a conventional video, but it looks like both of them are APRV. But you can see now all my alveoli are open. They're all recruited. And the patient is taking little teeny tiny volume breaths on top of the open alveoli. So that actually is what APRV is. Don't get flustered. Don't get upset when there's discussion about APRV. APRV means I'm going to open your alveoli with a mean airway pressure strategy and intermittently I'm going to release your mean airway pressure. That's the way to think about it. Mean airway pressure is what opens up your lung. Now, the very first publication, more than 20 years ago, 1997, with a primary anesthesiologist, who, by the way, I'm very proud to say, was at that time an anesthesiology fellow here at Grady, Christine Stock. She and John Downs published the first article talking about a style of breathing that meant we were going to use high pressure to open the lung, driving the mean airway pressure up, setting it at plateau +3 or mean pressure at +3, setting that high pressure to open the lung with an occasional short release. So when we look at how that actually comes about in a drawing, you can see you have a high pressure here. It's about 30 or 32, and you have it for about 4 to 6, maybe even up to 8 seconds. So open, 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 release. Open, 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 release. So it is a constant high positive airway pressure, intermittently released. And that's the way to think about APRV. How people describe it basically is CPAP. High CPAP typically is going to be 28 to 35. High pressure CPAP, also known as P high, for a prolonged period of time, known as time high, with intermittent, very short release down to a pressure of 0 to 3. So not 5, not 8, not 10. That release time is so short, your alveoli don't have time to collapse. So you've recruited, and you release that pressure in order to expel carbon dioxide. Fantastic, fantastic. And by the way, one of the most important keys here is that your patient breathes spontaneously on top of the high pressure, just like they would on CPAP. CPAP opens the lung, the patient breathes spontaneously. So I'm going to use a CPAP, like CPAP. It's actually called high pressure and high time, a pressure somewhere between 28 and 35 that is maintained over time to open the lung. And at the same time, the patient is going to have spontaneous breathing. He's going to also have pressure support to support that spontaneous breathing. So that pressure support is added onto that high pressure. So if I'm at, my high pressure is 30 or 35, and then I give you a pressure support of 8, that means that when you take a breath, your pressure will go up to 35 plus 8. So that'll be 43. The key here is the spontaneous breathing, which actually mobilizes the carbon dioxide into the airways so that when we release the pressure, CO2 goes bursting out into the environment or into the ET tube, as the case may be. So high pressure, high time, short release. High pressure, high time, recruitment. Low pressure, short time, release. Recruitment is about oxygenation. Release is about CO2 removal. Couldn't be more straightforward. Seems complex. It is complex, but philosophically, it's pretty darn straightforward. So there's a couple of really important principles when we're talking about airway pressure release ventilation. So again, it's just a continuous positive airway pressure with regular brief releases. Okay, now on your vent, it's going to call that frequency. This is not your respiratory rate, folks. This is your cycle time. So when you go into the room of somebody who everybody on rounds has said they're on APRV, and you look down in the bottom categories where you see frequency and it says 6 or it says 10, that is not the breathing of the patient. That is the cycle time of high pressure to low pressure. High pressure, high time to low pressure, low time. It's cycle time. If you look up on the top bar, you should see that your patient is breathing beyond that. So I may have set that cycle time at 10, meaning each cycle is a total of 6 seconds. 5.2 seconds is spent in high pressure, 0.8 seconds spent in low pressure. but my patient is breathing 58 times a minute. So that means he has 10 cycles and he's taking 48 breaths. And those breaths are little hummingbird breaths with very, very, very low tidal volume. Very low tidal volume, but very frequent breaths. And he's moving his CO2 out and he's oxygenating because he's been recruited. That long time at P high helps me to open up all those alveolar units that are slow to open because they have fluid surrounding them, they have dysfunction in the endothelial wall, and really, really important to appreciate this. We allow the patient to breathe unrestricted breathing during high time. And typically, in a really effective APRV, your patient's actual respiratory rate will be somewhere between 40 and 60, which makes nurses very anxious. Oh my God, he's breathing so fast, but he's not breathing like this. He's breathing like this, like a little panting hummingbird breath, small volumes that go directly to the alveoli. Fantastic. Such a great way to ventilate our patients. So we use this because we have patients who have low compliant lung disorder, like severe pulmonary edema, ARDS, sometimes with pneumonia, although it'll be much harder to recruit those patients. And typically we know that because they have a high peak plaque. They may also have obesity, they may have ascites and diaphragmatic thrust up into the thoracic cage. So basically they have thoracic restriction. We can use APRV in them. Typically, we say if our patient's P to F, remember that's PaO2 divided by FiO2 in the decimal, we always want that to be greater than 200. If it's 150 or less with an FiO2 of greater than 60% or 0.6 and a PEEP of greater than 10, that patient really qualifies for APRV. If we look at the patient and their peak inspiratory pressure is greater than 35 and their PEEP is greater than 10, we're going to think about APRV. And that means the first day that that's sustained, we should be talking about it. If we are using lung protective strategies, that would be low tidal volume, and lung recruitment strategies, higher PEEP. So we have a high PEEP, 12, 15, 16, and a low tidal volume, 6 mLs per kg, but the patient is not improving. We're going to think about APRV. And we can use APRV with pulmonary vasodilators like Flolan, Velitri, nitric oxide, eprostenil, or prone positioning. You can always use it with other interventions. Problem is that we don't want to paralyze the patient. We don't want to oversedate them. So proning them can be quite difficult unless they are comfortable turning over and being turned over, right? Otherwise, patients that you have on high PEEP and low tidal volumes, typically to prone them, you're going to need to paralyze them or use aggressive sedation. Why do we use it number 2? It significantly improves oxygenation compared to conventional ventilation, significantly. Allows you to reduce the FiO2. That actually protects the lung because remember, high levels of FiO2 cause oxygen toxicity. Requires a lower minute ventilation, which means that you're moving your CO2 better. And I'm going to be able to accept a lower minute ventilation. I don't have to overdistend the lung. And I'm actually going to prevent the repetitious open, close, open, close, open, close, open, close of the alveoli when I use APRV, because all alveoli get the open with APRV. And of course, decreasing the need for sedation. So now I'm going to take a good look at APRV. And you can see that I'm just maintaining the lung opening and the patient is breathing rapid, shallow breaths, but my lung is wide open. Every bit of oxygen I'm trying to deliver is going to get into the blood because my lung is wide open. And I know my lung is wide open because even though the plateau pressure, which I have to measure in assist control ventilation, I can't measure in APRV. So let's just say this, even though my mean airway pressure is high, what I'm actually seeing is that I'm able to reduce the FiO2. My mean airway pressure, that constant high pressure is high. My patient is able to move tidal volume. That tells me that he's opened his lung. Even when it's small amounts of tidal volume, when you add all those small amounts together, it's actually a pretty big tidal volume. Okay. So again, we're going to just remind ourselves about terminology. We talk about P high and P low, and a lot of times that's referred to PEEP low, PEEP high. It just depends on your ventilator. But the appropriate thing is to talk about high pressure and low pressure, high time and low time. Remember, high pressure, high time is actually about not really inspiration, but recruitment. And low pressure and low time is about release. And we're releasing that pressure that unloads the right heart. It also helps us to unload our CO2. So if we just take a quick look at this, this is such a beautiful schema of APRV. Unfortunately, an artist's rendition. Okay, so what we see is the vent actually applies the gas flow to get to that high pressure, which is around 34. And my patient's taking small spontaneous breaths with pressure support. These are all spontaneous breaths. The cycle of the vent is to open the lung, and the patient is taking his own spontaneous breaths. And then the pressure is released, and then it recurs. And that release time is about 0.6 seconds. This is 1 second, right? So this is about 0.6 seconds that I've released the pressure for almost the whole cycle. So from 1 to 4.5, I am on high pressure, and then I release for about 0.6 seconds, and then I reapply the high pressure. So open, 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 and patient is across open, and then release. And when I release, all that CO2 gets expulsed out into the ventilator. Okay, so again, we look at the same thing here. This is your pressure visual. This is your volume visual. And you can see it's a really small amount of volume. Now, the other thing that's important is during release, so you go from high pressure to low pressure, this also supports a volume. It's going to support a tidal volume, and in this case, it's a tidal volume of about 300 mLs. But these little spontaneous breaths are moving about 25 mLs, but he's having a lot of them every minute. And then this is, of course, your gas flow. Gas flows in, stays in, flows out, goes in, stays in, flows out. Okay, so we call that a Wind-Kessel effect. It's sort of like this tumultuous thrust of gas up into the airway, and during the airway pressure release, it's sort of like vacuuming that gas out of the airway. That's the Wind-Kessel effect, and that helps us to maintain or drop our CO2, which we can't do when we do something more traditional like pressure control inverse ratio ventilation. So high pressure, long time is oxygenation, short, low time prevents de-recruitment. The rapid release helps me to move CO2, and the difference between the high and low pressure actually supports a functional tidal volume that promotes that CO2 removal, and that's really important. So 3 basic concepts. High pressure, long time, oxygenation. Short, low time prevents the alveoli from collapsing, okay? The difference between your high pressure and your low pressure, your high pressure and your low pressure, that difference supports your tidal volume, which helps you to remove CO2. And that release from high to low gives me basically a vacuum effect to pull the CO2 out of my patient's airways. Okay, so this is a functional lung here, a lung that, in a patient who did die, a lung that was supported by APRV. Look at that beautiful lung, all pink, all healthy, very nice lung parenchyma on a longitudinal slice. And here is an ARDS lung with traditional FiO2, traditional tidal volume. You can see it's all necrotized, a terrible failure, lots of separation here across the alveolar lines, and a lot of necrotic tissue. Okay, so when we're ready to think about APRV, and we're going to transition from conventional ventilation, you as nurses are not going to do that, but you're going to support the patient, and you're standing by with your respiratory therapist as this is being done. So first and foremost, we're going to look at the mean airway pressure or the plateau, which just depends on your therapist. And they're going to say mean airway pressure in a pressure cycled mode. So I've got to put the patient on pressure, not volume, pressure control. And then I'm going to add 2 to 4 centimeters of water pressure. So mean airway pressure measured in pressure cycle plus 2 to 4 centimeters of water pressure. I'm going to set low P at 0 to 5. I'm going to set T high, which is high pressure, high time, 4 to 6 seconds, and T low at 0.6 to 0.8 seconds. Anything longer than that is not going to be a traditional APRV. It doesn't mean that it's wrong. It just means that If you let it be longer than 0.8 seconds, you're allowing time for the alveoli to collapse, which means a good portion of the next breath is going to be about recruiting the alveoli. What you want to do is recruit them and prevent them from collapsing, which is why you use this very short, low time for release. So I really love this chart. I think it's really, really helpful. Okay, so this is your P to F on whatever FiO2 you're on, whatever PEEP you're on. And if your P to F is less than 150, I'm going to give you a mean airway pressure of 25 to 28, less than 200, 20 to 25, less than 250, 15 to 20. I'm going to always err on the higher side because I want to recruit the patient quickly. Okay. And so then you look at high and low. So when we're talking about releases, if I set the patient at 17, which is way too fast, I'm going to be more towards 9 or 10. And that's 6 seconds on high and 0.5 on low. But you see that no matter how many seconds I spend on high, I'm always going to spend a very short time at low. So I've got you 3 seconds high with a positive high pressure at 20 for 3 seconds, and I allow an airway release of 0.5. That's going to give me a frequency of cycle time, not breathing, of around 17. If I have you on T high of 6 seconds and T low is 0.5, and I put you on this, and I've got you on a mean airway pressure or an opening pressure of 28 to 30, you're going to get 9 to 10 cycles per minute, 9.25 or so per minute. And I'm using a much higher pressure to open the lung. Okay, so really, really important to appreciate. You're going to advocate for this when plateau pressure is high, when dry pressure, which is plateau minus PEEP, is high, when your patient has failure of oxygenation. You're going to advocate for APRV. And then we're going to say, we're going to work with our therapist who's going to look at the mean airway pressure or the plateau pressure at 2 to 3, or use a basic chart. And typically we're going to have, the more the patient needs their alveoli open, the longer you need to be on high time. And you're always going to have the shortest possible low time. So 0.5 is about the shortest time. Most of us say 0.6 to 0.8. 0.5 is a pretty short time. It's cool. I'm okay with that. So T high range, 4 to 6 seconds. T high pressure right here. T low, 0.5 seconds. And the pressure is 0. Now, lots of times I see people set this up. They're really uncomfortable with having P low at 0. So they put P low at 5. Okay. All right. Don't sweat the small stuff. I want it at 0. You want it at 5. You're the doctor. I'm okay. Not 8, not 10. Can't do that because that completely obfuscates the purpose of mean airway pressure release ventilation. Okay. So congratulations, SICU. This is an SICU patient with gorgeous application of APRV. On the Puritan Bennett, that's called the bi-level. And that requires that your therapist knows how to set the flow rate correctly, but no problem at all. Don't worry. Okay. So we're on bi-level. Frequency is 10. That means you're getting 10 cycles per minute. Patient isn't breathing 10 times. Cycle time is 10. Your patient is breathing 30. So 30 minus the 10 cycles, your patient rate is 20 and the total rate is 30. Hopefully everybody understands that. Okay. Now, T low is 0.83. So your airway release time, that's all this beautiful dipping here, dipping in the pressure, dipping in the flow. That dip here is your airway release, and that airway release is down to 0. See how they set the PEEP at 0? I'm so happy. It was when I saw this, the first time I saw this, because a lot of times I mean, who cares what I think, but lots of times I'm not happy. You can see this is from 2017. I was so happy. We had such a great physician, surgeon who really understood APRV. PEEP low was 0. Low time, so low airway pressure 0, low time 0.83, high pressure 28, and high time, so your cycle time is 6 seconds. So your high time was about 5.2. So 6 seconds minus 0.83, that's T low. That means the rest of the cycle was spent in high time. Now you can look up here and you see that you are in high time for a long time with a short release. Everybody can agree. Everybody can agree. Now on your vent, you'll not see high time, you'll just see low time, T low. So you have to say cycle time. Cycle is 10. That means every cycle is totally 6 seconds. 6 seconds minus the time at T low is about 5.2. And really, so for Daniel, I'll say 5.17. So I kind of rounded that off, but I know Daniel's on there, so I want to be exact because I know Daniel likes to be exact. And that's the thing I love about him the most. By the way, that patient was on 100% FiO2 and now he's on 50%. He has great gas exchange. By the way, he's moving a tidal volume that's on the cycle breath, because the difference between high and low is the tidal volume of 880, but that's only on the cycle breath. In between, he's moving small tidal volumes, but totally he's got a minute ventilation. That's tidal volume times rate. So tidal volume times rate, his minute ventilation is 10 liters. So I'm anticipating that he's moving his CO2 very well. Now, if you look up here at the IE ratio, so it says 1.2 to 3. People think that means, oh, you spend 1.2 seconds in inspiration and 3. Oh, wait, no, that can't be right. 3 seconds in exhalation. That can't be right. No, that's because it's not right. You're spending 1.2 in high time out of your 6 second cycle. So 6 divided by 1.2 will give you that 5.13 and 0.3 of the whole cycle. So this is percent of cycle. 1.2% of the cycle is high time, 0.3% of the cycle is low time. But you don't have to worry about that. You just need to go down here. Okay. And you can see this is really fantastic. So my peak pressure is down. I don't measure a plateau here. I'm just going to follow the mean pressure because I'm in pressure control. Can't measure a plateau in pressure control because you're controlling the pressure. Cycle time is 10. That means total 6 seconds. 0.83 spent in low time, all the rest with each cycle of 6 seconds spent in high time. High pressure 28, low pressure 0. FiO2 is 50%. Fantastic. Fantastic. An incredibly beautiful methodology of really applying APRV for this patient. He's breathing a lot spontaneously. You have to work with him to help him be comfortable. He probably needs dexmedetomidine. You don't want to sedate the patient. You don't want to suppress their respiratory function. You need for them to be breathing spontaneously across high pressure time. So again, what APRV does is it gets you into that sweet spot so that your lung is open and small amounts of tidal volume will be distributed to the open lung. So I'm recruiting you with APRV. That recruitment is the high pressure, high time, opening that up. I'm limiting the tidal volumes, right? You're moving small tidal volumes so that we don't overdistend the lung. The more you overdistend the lung, the less you've opened the functional lung. And that's really important. And then this just gives us that same visual that we've looked at before. High pressure here, you're at around 26, and you're across that opening pressure of 26 with spontaneous breathing. Here's your T high, here's your T low, and your low pressure. So we talk about 4 things. We talk about 4 things. Sorry, and it's going to come up again. P high, T high, pressure high, time high. P low, T low. Okay, 4 basic things. P high, time high. P low, time low. What you're going to see displayed on your vent is your P high, but not your time. Your P low and your T low. But you can always figure out T high by taking your cycle time, 10 cycles per minute, 10 divided into 60. Every cycle is 6. Subtract the 0.83. The rest of that time is spent in T high. T high, P high, oxygenation. P low, T low, ventilation. Pretty straightforward. Now, we're going to compare APRV. This is a Draeger vent. This is not the vent that we use, but if you understand vents, you can basically look at them and make a pretty good decision. Okay. So I'm looking at this vent. Okay. And I'm saying, all right, I'm probably have a high pressure of close to 22. I can see it right here. And there it is right there, close to 22. And I have really 0 PEEP. Okay. All right. That's in your APRV. And your cycle rate is 13. Okay, now we go over here and you're looking at this patient. He's in pressure control BiPAP, which is also a form of APRV. BiPAP can be a form of APRV, and basically it's set very similarly here, except that you have a much longer exhalation time. Now, we don't use BiPAP for APRV. We use bi-level or actual APRV settings. Now, you might, especially if you've been around for a little while, you might say, well, gee, that sounds like inverse ratio. Prolonged I time and a short E time, where I inverse inspiration and expiration. But if you notice here, in true pressure control inverse ratio ventilation, patient is not allowed to breathe. He can't breathe across high time. He can't breathe across low time. He just gets cycles. And what often will happen with pressure control inverse ratio ventilation is patients will retain CO2 and we will actually see barotrauma. Then we move to APRV. APRV is the same thing, high pressure with a short release, but my patient's allowed to breathe across high time. In true APRV, patients only breathe spontaneously across high time. So high pressure, high time, patients breathing spontaneously on top of that. True BiPAP, patient breathes across high time and low time. So he's breathing spontaneously equally here. And this is a weaning strategy, really, from APRV. APRV is basically continuous positive airway pressure with spontaneous breathing across a very high continuous positive airway pressure, typically around 30, with a very short release cycle. So very straightforward criteria, just a wonderful little chart that just reminds us that we're looking at patients who are requiring a lot of FiO2, and most likely they're requiring PEEPs greater than 10. We're going to put them on P high, P low, T high, T low, exactly what I've talked about. Okay. The therapist sets that by talking about expiratory flow, again, around 0.6 to 0.8 seconds. And again, P high is typically going to be plateau pressure or mean airway pressure plus 2 to 3. Okay. These are not mandatory breaths. These are mandatory cycles, and the patient takes spontaneous breathing. And we want patients to have at least 10% of their total breathing is spontaneous. So we are going to set it in very particular ways. Okay. So now again, APRV terms. P high, the baseline airway pressure level. P low is the airway release, and that's typically called PEEP low, depending on your vent. T high, the length of time that P high is maintained. Time at PEEP is the time spent in airway release at P low. Okay. P high, T high, recruitment. P low, T low, release. Fantastic. Really straightforward. The 4 things you need to know. The 2 things from the patient, P plat minus PEEP, dry pressure. P plat. 2 things you need to know from the patient, P plat minus PEEP, which is dry pressure, and P plat. 4 things you need to know in APRV, P high, P low, T high, T low. Pretty straightforward and pretty darn fantastic. Okay, very good. So P high overcomes those collapsible forces. Also, the fluid load in the interstitium opens up the lung, and it positions your lung at the top of compliance. It's opened this lung beautifully and positioned the lung at the top of compliance. Because you're opening up more lung, you prevent overdistension because more lung is open. So the volume is distributed across a larger surface area. This is considered a constant recruitment maneuver. T high, P high create an avalanche of recruitment. That's what I call an avalanche, or a tsunami of recruitment. Okay. Increasing that mean airway pressure by having P high and T high over a long period of time, increasing that mean airway pressure increases the lung volume. It's fantastic. And it's a wonderful way to ventilate. Seems a little bit counterintuitive. P high, T high, recruiting for oxygenation. With that makes sense. But also T high can improve your CO2 clearance because the spontaneous breathing of the patient across T high and P high, that spontaneous breathing is mobilizing the CO2 up into the more proximal airways so that when you release the pressure, you expulse the CO2. So that seems a little bit counterintuitive. It would seem to us, because normally when we say, well, you're applying all that PEEP, that's going to prevent the removal of CO2 because I'm trapping gas in the lung. The difference here is the patient's going to be breathing spontaneously. And that's a critical point in true APRV. Now, release phase is considered by the ventilator as the exhalation phase. But really just remember that that's what's actually going to determine your tidal volume. It's going to release that pressure. It's going to unload the right heart, improve the stroke volume from the right heart, and therefore the filling volume of the left heart. Fantastic. Really a fantastic methodology. Okay, so I put the patient on an APRV, but he isn't oxygenated in the way I want him to. So the first thing I can do, of course, is, as always, increase FiO2. I can increase P high, and I'm only going to do that 1 to 2 centimeters per change. So I started at 28. Now I'm going to go to 30. I can increase T high, the time. So I started with 5 seconds. Now I'm going to go to 5 seconds. I started at 28. Now I'm going to go to 30. So I'm increasing P high and T high. And I'm going to give the patient a bit more pressure support for their spontaneous breaths across that T high. Okay, so very, very important. And unlike spontaneous breathing or assist control, where PEEP actually, if the low PEEP, right, at the end that we talk about PEEP being end expiratory or the expiratory phase PEEP, has a minimal impact on oxygenation. And T low does not really impact oxygenation. P low, T low, mostly about CO2 removal. Okay. So again, increasing T high, the problem when you increase T high is that you're going to decrease the number of releases. As you decrease the number of releases, the potential is that you're going to retain CO2. So I'm trying to oxygenate you. I increase your P high and I prolong your T high. That means I'm going to have to get rid of some of my releases. So I was on a cycle time of 10. Now I'm on a cycle time of 8. Okay, what's going to be profoundly affected is my release frequency, and that release frequency is when I'm going to get rid of CO2. So that's going to be really, really important. If I am trying to increase ventilation and CO2 removal, okay, increasing P high will raise your tidal volume, but decreasing T high will also be important. Okay, so let me repeat this. To improve oxygenation, FiO2, increase P high, prolong T high, increase CO2 removal, increase P high, shorten T high to give more releases. If I give more releases, you'll be able to remove more CO2. And again, I'm going to consider increasing pressure support to just give you a bit better volume mobilization, as volume, of course, removes CO2. So want to remind you that control settings for CO2, P high minus P low, is actually going to determine the volume exchange for you to expulse your CO2. But you have to have enough releases per minute. I have found, for me, optimally, that somewhere between 9 and 10 cycles gives me adequate release time. But if my patient is retaining CO2, then I am actually going to reduce his cycle time, so I can increase his cycle time. I'm going to increase his cycle frequency so that I have more time for exhalation. Okay, pros and cons. You can tell I love APRV. It recruits your alveoli. It improves oxygenation with a lot less stress on the lung, with a much better benefit for lung protection, allowing me, as long as I'm working with the patient at the bedside, talking to them about how they should be breathing, they're going to feel like they're suffocating because they have that gas flow over a long period of time. They feel like someone is forcing gas in there. I've got to work with them, help them learn how to breathe with the ventilator, become jiggy with the ventilator, be zen with the ventilator. That takes some time. And if I can't get the patient to be comfortable with it and he's just anxious, then he's going to feel APRV. Okay, but it's very significant in terms of reducing cardiac workload because of that release pressure. Okay, there are a lot of disadvantages as well. I'm asking the patient to breathe spontaneously, so he's going to work. He's going to have to work hard. He's going to be moving volumes on his own across that high pressure. That requires work, and he's going to increase energy expenditure. Also, you may have some development of fistulas, bronchopleural fistulas. You may be more at risk for pneumothoraces because of that high pressure. There may be some increased risk for volutrauma of the functional alveoli. And if we're not careful about how we set it, this may actually cause some venostasis in the central veins, causing an increase in intracranial pressure. If we're not careful about balancing our release, may also worsen cardiac output. So we think about the advantages and the disadvantages, and then basically understanding there's 4 potential hypotheses. APRV or bi-level, not really BiPAP, APRV bi-level, better than assist control, number 1. Number 2, APRV bi-level, worse than assist control. Number 3, there's no difference. And number 4, it's undetermined. So what does that mean to you? What it means is try it. Advocate. High P-plat, high distending airway pressure, which is P-plat minus PEEP, not oxygenating well, going up on FiO2, have a discussion. Does this patient meet criteria for APRV? Discuss it first with your respiratory therapist, then together discuss it with your providers. Think about utilizing APRV, try it. Typically, what you're going to see, and we're going to see that in the case study, is that patients are going to respond to this pretty quickly. It has to be introduced early before the lungs are really friable, before you've really lost lung function. So let's take a quick look at a case study. This is not my patient, it's someone else's case study. I've been given permission to share the case study with you, and I'm really grateful for that. But it is not my case study. Yeah. So someone asked what APRV and bi-level looks like. We use bi-level. We call it APRV. It's called the trademark on the Puritan Bennett is bi-level, but they are the same thing. The difference is just flow dynamics, and your respiratory therapist is going to set that. So what I showed you was APRV saying bi-level because that's the patented word on your ventilator, but you were truly in APRV. You were not in bi-level. Bi-level is BiPAP. That means patient breathes spontaneously high and low. And no, I don't have a picture of it because we don't use it. We use bi-level and we adjust it to give APRV. Okay. Patient's a 44-year-old female admitted trauma ER after T-bone motor vehicle accident. Prolonged extraction using jaws of life, freeing her from the vehicle. Her initial vitals on site were GCS of 6, heart rate 136, blood pressure 75/40. They attempted to intubate her twice, but they couldn't do it. So they rushed using bag mask, rushed to the ECC. Patient goes into trauma ER and gets a rapid sequence induction with etomidate, sucks, 2 liters of saline, 4 units of packed red cells via mass transfusion protocol. So this is an older protocol. Obviously, now we give you whole blood first before we give you any packed cells. She got a bedside abdominal ultrasound, chest x-ray. She had bilateral pneumothoraces, pretty significant injury, prepped and received 32 French chest tubes. Immediately taken for CT of head, chest, abdomen. And on secondary evaluation, she has a lot of injuries, right? Aortic pseudoaneurysm and mediastinal hematoma already occupying space in the thoracic cage. Grade 5 liver lac, grade 3 splenic lac, grade 2 right kidney lac, adrenal hematoma, bilateral rib and sternal fracture. So you know already she's going to flower pulmonary contusion. She's going to develop ARDS. And then she has a trace subarachnoid hemorrhage, but didn't need neuro, non-displaced occipital condylar fracture, and a right maxillary frontal process fracture, and a right scalp hematoma. Boy, very bad, right? This is very bad. Okay, so immediately went to the OR for abdominal exploration, repair of the life-threatening injuries, including the stenting of her descending thoracic aorta, and she goes to SICU for post-op treatment. On arrival in SICU, she's in respiratory failure, profoundly hypoxemic with severe lactic acidosis. I'm just going to give it to you. Lactic acid level was 9. Her base deficit was -18. She's pretty darn sick. Okay, so post-surgical ICU report coming from the OR says, oh, her heart rate's 114, blood pressure is 100/50 with a MAP of 62, respiratory rate 88, SpO2 92, her RAS score is -2. She's on assist control ventilation, rate of 18, tidal volume of 420, 5 of PEEP, 60% FiO2. Okay, and you can see all the things that are happening. She has 2 peripheral venous lines. She has a CVP catheter. She's got norepinephrine on board and mics per kilogram, propofol, fentanyl, and she's getting saline wide open. She's received a total of 8 units of packed cells, 2 units of platelets, 6 liters of normal saline. A really terrible MTP protocol here, very bad MTP protocol. But that's not the purpose of our talk. Okay, so now in the ICU, we're kind of addressing some things. Her PEEP now is at 8, FiO2 is 60%. respiratory rate 18 on assist control, tidal volume 420. She's not overbreathing the vent. She is actually exhaling in tidal CO2 of 54, which means she is hypoventilated. And tidal CO2 is high, you're hypoventilated. Her PIP is 32 and her P-plat is 28. Okay, not terrible. I'm not really happy, not terrible. Then we look at her blood gases. pH 7.2, CO2 is 59, PO2 61, bicarb is 18. She must have gotten some bicarb and a SATs of 91. And now her end tidal CO2 is 40. So we're doing a little bit better job on ventilating her. We've adjusted her vent a little bit. And her P to F ratio is 100. So less than 150. And her PEEP is at this point at 8. When we look at her chest X-ray, her ET tube is in the appropriate position. The chest tubes are in the appropriate position. She has bilateral atelectasis and a right lower lobe large infiltrate. And the problem is looking at it, don't really know, is it infiltrate, atelectasis, or pulmonary contusion that's flowering? In any case, her lung is going to become non-compliant. So here's her chest X-ray. This is the first X-ray that we get. Okay. So, sorry. So sorry. I'm just going to, I animated that, but for whatever reason, the animation didn't take. So let me just dissolve that in. Okay. Go back. Thank you for your tolerance. Okay. So after the blood gas and the chest X-ray and observing her, the decision was made because of how she was looking. Her peak pressures were going up, her P-plat was going up. She was becoming more and more hypoxic. The decision was made to switch her to APRV. And here are the settings. P high 30, T high 5 seconds. P low 0, T low 0.5 seconds. So her total cycle time is 5.5 seconds, which is about 11 cycles per minute. P high 30, P low 0. Time high 5, time low 0.5. And immediately, she's saturated. So immediately, FiO2 was reduced from 60 to 40% within 10 minutes of the change from assist control to APRV. Okay, so this is how her APRV looks on the Draker ventilator. That's the Draker. That's not what we use. Here's her P high. Here's her P low. Here's her cycle time. I said 11. It's 12. Here's her tidal volume 425. This is the 60%, but then it was dropped down to 40%. Then we look at her blood gases over the next period of time. 2 hours on APRV with an FiO2 of 40, 6 hours APRV FiO2 of 40, 12 hours APRV FiO2 of 40. So look at what she does here. pH 7.39, CO2 is 50, PO2 is 69, bicarb 26, because now she's starting to compensate. Okay. And PF ratio 172. Now remember, her PF was 100. Now she's at 172, and she's releasing volumes, which is that's a tidal volume breath of 450 to 500. Fantastic. 6 hours later, and so some adjustments are made, right? Just a little bit of adjustment is made. So basically, P high, P time perhaps was adjusted. Now pH 7.4, CO2 is 40, PO2 is 80, bicarb 24. Beautiful SAT 96%. Release volume still 450 to 500, but now her PF ratio is 200. So she started at 100, then she went to 172, now she's 200, which is saying the gas you're giving the patient's getting into the blood and she's oxygenated. And then we move forward 12 hours post APRV, still FiO2 of 40, 7.34, 40, PO2 148, bicarb 21, SATs 99%. Release volumes now higher because we've recruited more lung. Her spontaneous volumes, that's breathing across high pressure time, her spontaneous volumes, which we didn't see here, but now she's breathing spontaneously and moving 200 to 300 cc's per spontaneous breath, and release volume 500 to 550. Oh my God, you've opened her lung. And it took about 12 hours. So you typically are going to start to see some responsiveness in the first few hours. Takes about 12 to 24 hours to maximize responsiveness. And you can see here, this is a great case study. It's a real patient, just not our patient. And it's really a beautiful presentation of the possibilities of early intervention with APRV, which is about driving up the mean airway pressure, opening the lung, protecting the open lung, recruiting the non-open lung, and providing better blood flow dynamics. So really, really important when we're talking about that and understanding the purpose and the relationship of APRV. Here's her first chest x-ray. Here's her chest x-ray 12 hours later. Honestly, everybody deserves a trial. If they're on high FiO2, high PEEP, and they have a low compliance lung. We know you have a low compliance lung because your P plat is high and your dry pressure is wider than 15. Remember, you just need to look at your patients and advocate. Is the oxygen I'm giving the patient getting into the blood? That's the P to F ratio. What's the P plat? What's the dry pressure? Does this patient qualify for APRV? FiO2 greater than 60, PEEP greater than 10, loss of lung compliance. P plateau greater than 25 or 30, loss of lung compliance. Have a discussion. It never hurts to discuss what the options are. You may discuss it on ears that are willing, ears that are unwilling, but your role is to advocate and discuss options for your patient. And you are standing at the bedside, observing all of this. You need to know how to put it together in a communication which drives your providers to try alternatives to try to recruit the lung. Does everybody improve? No. Do we know that APRV is always better than ACMV or SIMV? No. But in a patient who has greater than 60% FiO2, high plateau, wide drive pressure, high PEEP, they deserve a chance. Rather than staying in your unit, being hypoxemic, very slowly being PEEP wussy and saying, I'm going to add 2 a PEEP, I'm going to wait 6 hours. I'm going to add 2 a PEEP, I'm going to wait 6 hours. And by the time you get to a PEEP that might have opened the lung, that lung is already friable. We can't continue in this way. We always want to be able to discuss options for our patients. So just want to tell you, there's lots of studies, not anything that I saw actually, there was a great study that was just published in 2023, and I didn't put it on this list, so I need to put it on the list. Just published in 2023, looks much more hopeful about the role of APRV. You can see here that these weren't so hopeful, but it was about when it was being applied and how it was being applied. And remembering that when we say APRV, we're talking about a trade name. That trade name is used by Draeger and Hamilton for APRV. Bivent is on servo vents. Bi-level is what Puritan Bennett calls it. It's still APRV. You don't need to look at the difference between bi-level and APRV. It's a form of APRV, it just requires flow adjustment. And then with GE, it's pressure control APRV, and with Viasys, Avaya, which I think is no longer the name, somebody else bought them, APRV is called biphasic ventilation. So lots of different names, all for the same thing. High pressure, high time, low pressure, low time, short, low pressure, can't breathe during low time, breathe on high time, APRV. That's APRV. Whether the label says APRV, you can look at it and say, indeed, that's APRV. High pressure, high time, low pressure, low time. Cycle really should be 6 to 8 seconds, high time. Fantastic. I hope that this has been a good learning opportunity for you. I'm always so grateful that you joined. I thank you very much for your dedication to patient care and to promoting knowledge and progression of your own knowledge for critical care. I'm so grateful you joined me. Hope I'll see you tomorrow when we talk about the right heart, EKG, and CVP. And of course, every week, different talks, same time, same website. Thank you so much. Those of you who are on the call, please, if you wish, please stay on so that we can have some discussion, questions and answers. And for everyone else, ta-ta for now. Thank you very much.